I came here 3 years ago, the first time to talk about healthcare, and it provoked some pretty active discussion. There were some people who took offense at some of the things I said. I hope today I get the same kind of response, because I'm going to damn the healthcare system a little bit. Before I start, I want to tell you a quick little story. First of all, I'm amazed at all the people that came out this morning. I'm always impressed when I look at the size of this audience. It reminds me of a story. A friend of mine, Frank Oski, who was chairman of pediatrics here back in the 70s, and went to Hopkins. We used to do a great amount of lecturing in the central New York area as part of the graduate medical education program from upstate. And sometimes in the middle of winter, it could be pretty hairy driving to the various cities. And Frank told the story of on a winter night in January in a snowstorm driving to Cortland. He finally arrives at the Cortland Hospital, goes into the lecture room, and there's one other man there. And Frank says to him, "You know, I really appreciate your coming out to listen to me on a night like this." And the guy said, "What do you mean listen to you? I'm the second speaker." And sometimes we would make trips and it would be pretty awful. Okay. As Lou said, I spent a lot of time in medicine, some 50 years. I graduated in 1945, but I was only 12 years old. And I did a lot of stuff early on, both administratively in the hospital system, hospital planning, and as Lou said, I was the president of the Crouse, and I was the first president of the Crouse Memorial before I went full-time with the school. And I really thought I understood the healthcare system. And to this day, I thought I understood the healthcare system. But I was wrong. Wrong, wrong, wrong. My first piece of information about the healthcare system that was new to me was when I was out in Santa Barbara in the wintertime, as we go there regularly, and I had a lesion on my face. And I called a friend of mine and I said, "I need a dermatologist." Friend said, "Well, here, I'll give you the name of the best one in town." I said, "Doesn't matter, I just want a dermatologist." I called the office and the secretary said, "Are you a patient of the doctor?" I said, "No, I'm new in town, but I got his name from another doctor." She says, "Oh, I'm sorry, doctor doesn't take new patients anymore." I said, "Doesn't take new patients?" "Nope." "Well, can you give me the name of someone else?" "Sure." Gave me the name of another doctor. Call that doctor. I said, "I need to see the doctor." I got his secretary. I said, "I have a thing on my face, a little bit concerned about." And she said, "Fine, doctor will see you." I said, "Well, when?" She said, 3 months. I said, "What?" By that time, I could be in terrible trouble. "Well, can't do that. Can you give me the name of somebody else?" "Sure." The third doctor couldn't see me either for 3 months, but she had an assistant who just joined her. And that doctor saw me in a week. The lesion was malignant. It was a basal cell. I'm sure some of you have had them. I had it off, and that was the end of the problem, but I was shocked. And then, some 6 months later, a year later maybe, my wife had a problem. She had had some surgery years ago, and she had a recurrence of the problem. Called the surgeon's office, told him that she was really quite uncomfortable and she wanted to see the surgeon who had operated her. "Oh, he can see you." 3 months. She said, "But I'm uncomfortable." "Sorry, he's very, very busy." Fortunately, we were able to get somebody else that saw her in a week and took care of the problem. Doctors that don't see patients, doctors who can't see you for 3 months, doctors' offices that tell you if you're uncomfortable, go to an emergency room. When I started the practice of medicine in 1951, that would have been unheard of. Unheard of. Something had happened to the practice of medicine. So I got kind of interested in this, and I'm going to take my coat off. One of the things that happens when you do this is you work up a sweat. Okay. So I decided to look into this thing about healthcare in the United States. What had happened since I had retired in 1991 that had produced this kind of thing. And I found a lot of literature, both lay literature in the great medical journal, the New York Times, and in some of the medical journals I still read that looked, but most of it was on the Obama health care plan, the Affordable Care Act. There was a lot of stuff about the VA, the problems with the VA. And in addition, I found a very interesting article from a group called the Commonwealth Fund that said the American healthcare, in terms of the quality, was 11th in the world. Couldn't believe that. 11th in the world? In any event, I found very little that dealt with the problems I had faced. And so I decided to do my own research and write my own paper. And by the way, when I used to lecture at the medical school, and I used to produce 3 lectures a year, I knew exactly how long the lecture would run. It was 29 to 30 slides, and it was about 5 pages of writing, scribbling. This talk is coming out of a paper I wrote. I've never had to do this, to prepare a talk from something that I wrote. I'm going to take my watch off so I can watch my time. In any event, so it's been a little tricky, and if I suddenly gasp or start looking down at things, you'll find out that I'm just lost. I've forgotten where I'm at. But in any event, so I started to look at things, and what I found bothered me a great deal, because there were things going on in medicine in terms of cost and in terms of quality of care that bothered me. They just were most unique to us. And I finally decided that the major problems in America could be best described by 2 things. I think that first slide, if I can do that. No, that's by numbers and by mix. We have a numbers problem in this country, and we have a mix problem. Let me define what the numbers problem is. The numbers problem is we don't have enough doctors. Plain and simple. The mixed problem is that our doctors are not the kind of mix we need to take care of people. We have an overwhelming number of specialists and subspecialists at the expense of primary care doctors. Let me define some of these terms for you. A primary care doctor is a doctor who sees all comers. No matter what the complaint is, you call that doctor, he sees you, or he or she sees you. A specialist is someone only sees patients who have problems related to their particular field of interest. For example, an orthopedist for bone problems, ophthalmologist for eye problems, or a dermatologist for problems with the skin. You don't get to see them first off, you get referred to them. Okay, with that definition, let's talk first about numbers and then we'll go to mix. Currently in the United States, we have 143 medical schools. There were 2 that just came on site in the last year. We have about 75,000 medical students. That seems like a lot, doesn't it? 75,000. But it's not. We graduate 18,500 approximately per year. Now when they graduate, they don't immediately go into practice. They're not really ready. They need to be fine-tuned. And so they go into postgraduate training. That postgraduate training takes anywhere from 2 to 6 years. Some actually go as long as 8 years, believe it or not. And the length of the training is dependent upon what field of interest they choose. If they're going to do family practice, your old GP, your general practice, it's now called family practice. If they're going to do family practice, it's 2 years. If they're going to do internal medicine, it's 3. If they're going to do a specialty, it could be anywhere from 3 to 6 years. Some of the surgical specialties require even more, neurosurgery, for example, before they're ready to graduate. Now, when they graduate and enter the healthcare system, they depending upon what they do, well, I'm going to backtrack a little bit. May I have the next slide, please? When they finish, before they even graduate, for their postgraduate training, there are, believe it or not, 30,000 residency positions in the United States for graduate training. Since we're only graduating about, and by the way, the 30,000 works out to be, the number 30,000 occurs because that's the need, perceived need for the number of doctors we need in the country to enter the system to make up for the size of our population, the growth, together with the numbers of doctors who retire or die off. So of that, so we have 30,000 postgraduate positions. 18,500 makes up about 60% of those postgraduate training positions. We need another 12,000 doctors, approximately, to fill the remaining slots. Where do they come from? They come from other countries. They come from India, from Pakistan, from God knows where. Interestingly enough, of the 12,000, and I kind of rounded it out, it's actually just a little bit less, about 40% of them, or about 4,800, are Americans who couldn't get into medical school in this country. Couldn't get in. And about 7,200 are foreign-born, foreign-trained. Now, in order to make up for the shortage of physicians that we have in this country, we are taking approximately 12,000 students a year, the majority of which are foreign-trained and foreign-born, to make up the shortage. The number system, the number problem. In addition to that, we have another group of people who now provide health care that didn't provide it back when I was a young man. And they're called nurse practitioners or physician assistants. Nurse practitioners, by definition, are women or men who went through nursing school and then got an additional 9 months of training, 9 months of training or up to a year, to learn how to take care of patients like doctors do. Physician assistants, PAs, are usually men or women who worked in the service as medical corpsmen or corps women, and who, when they finished the training in the service, entered the healthcare system here working for a doctor. Now initially, these people were under close supervision by their doctors. And many of them had to get licensed in the state. That's no longer so. From my observation, they work almost independently. We'll see you, take care of you, even write prescriptions. And you never see a doctor. You call a doctor, but you don't see a doctor. Now these people are very capable, they're very competent, and I'm sure they do a very good job. But their training is far less than a doctor. There's more chance for mistake, more mistakes. And in addition to mistakes, they're more apt to rely on testing, which costs money. There's really no saving to the system because, in fact, the system gets billed for a doctor visit. You don't get billed for less because you saw a nurse practitioner. That's for sure. So that's how we have solved our numbers problem. We have a whole new group of people called NPAs or nurse practitioners, and we're relying on foreign-born, foreign-trained physicians to make up the shortage. The problem is not enough medical schools, not enough doctors. A numbers problem. Makes it hard for you to see somebody when you don't feel well. The mixed problem is a lot more complicated and requires a little bit more definition. The healthcare system, when I was part of it, was made up primarily of primary care doctors. Again, primary care, they would take care of you no matter what the problem was. We had a handful of specialists, and there was no such thing as a subspecialist. But that all began to change after World War II. When I went to medical school, the faculty for the first 2 years, before we actually saw patients, was made up of full-time people. They were not MDs, most of them were PhDs, and they taught courses like anatomy and physiology, biochemistry, and so on. The clinical years, the last 2 years of medical school, were taught back in those days by men in practice here in the community. The professor of surgery was Albert Swift. E.C. Reifenstein was the professor of medicine. They were wonderful teachers. They were wonderful healthcare providers, but no full-time people. The only schools that had full-time faculty back in those days were some of the two or three of the major schools in the country, like Johns Hopkins or Harvard, let's say. But after World War II, it began to change. And in 1947 in Syracuse, we had our first full-time faculty member who was brought in, Dick Lyons, who was chairman of medicine. And Dick became immediately upset with the quality of what he thought was the teaching staff, and he brought in his own specialist, rather. He had 3 specialists helping him teach, and he insisted on a full-time radiologist, and gradually, each department developed its own full-time faculty. And that was really the beginning of the change in the way medicine was constructed. Because these people, as you came through training, as you rotated through various specialties, would kind of actively recruit you into their specialty. And so we began to see a change in the direction of medicine. And I think next slide will. Yeah, we began to see a change. I won't use that. Let's go back to the other one. We began to see a change in the makeup of doctors in this country. We began to see more and more specialists at the expense of primary care doctors. In the mid-1960s or maybe early 70s, there was a study done by the Institute of Medicine looking at this change, this trend, looking to see whether this could have any negative impact on the delivery of healthcare in this country. And it concluded that it would not. It said, no, primary care doctors, yes, they can function seeing all patients, but specialists will see primary care problems as well if their patients develop them. Well, that's not really true, because if you get into this, if the primary care doctor takes all comers and a specialist only sees referrals, then the amount of primary care they do is almost minuscule. But once they came out with that defense of the system, I knew the system was doomed, and that we were going to have more and more specialists at the expense of primary care providers. In this country, at this time, we have about 65 to 70% specialists and subspecialists, and about 30 to 35% primary care doctors. That's a bad mix, because the major problems we face are problems that primary care doctors should deal with. In Europe, it's just the reverse. They have been able to limit the number of primary care specialists at the expense of primary care providers. And so it's much easier to get into the system in Europe and in Scandinavia and Canada than it is in our country. We have just too many specialists. Now, does that actually improve the quality of care, having all these specialists? No, it does not. And I can say that with confidence because studies that have looked at outcomes show that ours are no better, and in some instances worse, than they are in Europe and in Scandinavia and Canada. Now, I said that or something like that about 3 years ago, and people challenged me on that. And it is true that we have centers of excellence in this country. I mean, you go to Mayo Clinic, you go to the Leahy, you go to the Anderson for malignancies. We have centers of excellence where the quality of care is superb, but they are unique. And in the general country, in the overall picture in this country, the quality of care really is not as good as it is in other countries. As I said, the Commonwealth Fund suggested we were 11th in the world in terms of outcomes. I'm not sure how they define outcomes, whether it's length of life or success of treatments, but we are no longer number one. The system is not functioning well. Now, as the pressure has grown to develop more primary care doctors, medicine has begun to respond. And if I can have the next slide, they have gradually increased the number of training positions for primary care providers over the last 4 or 5 years. But in the 2016 match, which again is the postgraduate training system that matches doctors with training positions, we have still 56% specialists and subspecialists and 44% primary care. That will not cut the mustard. We need more primary care doctors. The cost system comes into play here too. We are the most costly healthcare system in the world. We're spending about 18% of the gross national product for healthcare. The rest of the world spends about 11%, and their results are better than ours. One of the reasons why healthcare is so expensive is because specialist care is expensive. No way you can avoid it. The initial payment for specialty care is higher than it is for primary care. In addition, specialists do things on people. And when you do things, you get paid for it. And the reason for that, and I'm going to digress just a little bit, is because of the way we developed payment for healthcare in this country. When I was a young doctor, the only available payment for a medical visit was for surgery. In the 1930s, surgeons were not being paid for the procedures they did because of the Great Depression. No one had any money. And so they finally worked out a system to indemnify what they did, and it was called Blue Shield. And you got paid for what you did. There was no payment for what medical doctors did until the 1950s, when they finally included medical care. But the system was, you got paid for what you did. It's called fee for service. I know some of you have heard that term. So somebody, two people nod. Either that or they're sleeping. Anyway, fee for service. And fee for service works out this way. The more you do, the more you make as a doctor. You don't get paid for thinking. You don't get paid for sitting down and talking to a patient, working out a problem. You get paid for doing things. And specialists do things. They put tubes inside of you in various places. They put catheters up through your veins. They do all kinds of tests. And they get paid for them. So the more they do, the more they get paid. And that creates a peculiar paradox, because the cost of care goes up, but the quality doesn't. And the paradox is this: in medicine, at least, the more you spend doesn't necessarily mean the better the outcome. Now, I sometimes hear patients say, oh, my doctor's so wonderful. He has me come in every month or two. He does these tests on me. He's so careful about my care. And indeed he is, but at the same time, he is increasing his or her income. It's an income provider. And it doesn't always mean better care. It's a tough concept, but it's true. Anyway, so we're still in the system in this country where the specialists and subspecialists outnumber the primary care doctors. Now, students love that. They want the system, as does the healthcare system. Why do people want to be specialists over primary care? Well, I've mentioned the first, you make more money, and I think there's more prestige. Oh, my doctor's a neurosurgeon. Or not, in contrast to saying, oh, my doctor's a GP or a family practitioner. There's a certain cachet to being a specialist, along with making more money. But in addition, the lifestyle's a little bit better, a little more organized. The body of knowledge, the greater the narrower the specialty, the less the body of knowledge you need. There is constant recruitment by medical faculty for our good students to go into their specialty. and of course the income that I've already talked about. All of these things are very attractive and direct people away from primary care. Now, next slide. I'm not sure where I am. No, I'm going to hold that for a minute. So, along with the problem with numbers and mix, we have now created two distinct problems for people who are consumers. And I call those availability and accessibility. And let me define those. Accessibility is the ability to get into the system to find a doctor to take care of you. And availability is to find a doctor who will see you in a reasonable period of time. Both of those problems now become major in our healthcare system, in contrast to others. Now there are problems with the other systems that we don't have in this country. When I start talking about healthcare in this country, people say to me, well, we're the best in the world. And I know that because people come here because they can't get seen on time in Canada or in wherever. And the answer is yes, that does happen in these countries. When you don't have unlimited resources, the R word comes in, rationing. There has to be some rationing. You can't just spend money indiscriminately. Now the federal government, in an attempt to get control of cost, has been looking at the things doctors do as it relates to outcome. If I see you, you've got a backache, and if I do an x-ray of your lower back, and I find nothing wrong, and I treat you and you get better, and I compare that outcome to the doctor who doesn't get the x-ray, but just merely treats your symptoms, and the outcomes are the same, but the cost is greater for the first procedure, then why do the x-ray at the first interface of someone with low back pain? Now, in this country, we treat people as though we have unlimited resources, but we don't. In the rest of the world, they recognize the fact that they are limited in terms of what they can do, and if a process or a procedure does not alter outcome, or in terms of either quality of life or length of life, then it isn't warranted doing. People get upset. People get upset. I had a patient once who said to me, you know, I'm very well-to-do, and if I come into you, when I gave him a talk like this, and I want an x-ray, I want it. I'll pay for it. I don't care, but I want it. And lots of people feel that way. One of the examples I use when I talk about that is mammograms. Mammograms, fascinating subject. About 3 years ago, you might remember, an extensive study looking at the value of mammograms was done. Turns out that in terms of outcomes, mammograms done on women under age 50 with no family history of breast cancer and with no physical findings do not improve outcome. And so the recommendation was, do not do mammograms under age 50. There was a hue and a cry. People were screaming. Everybody had an anecdotal thing which said, thank you, Marty, I'm probably going to need it. Which said, everybody has someone who they knew was under age 50 who had breast cancer. Well, there are such situations. But if you look at the overall picture, if you look at the cost for discovery in a situation where you have limited resources, limited incomes, it turns out there is little or no value in doing mammograms in women under age 50 who have no family history of breast cancer and no masses that are felt on examination. But the public in this country, who are used to having unlimited resources, rebelled against that. Just within the last 6 months, another study done defending that position. But I doubt very much is up whether we'll see any change. And let me give you a perfect example of what can happen in that situation. I had a friend who had one of these Cadillac healthcare systems. and his wife had a physical exam. She was 38, no family history of breast cancer, no masses. Had a physical examination, and nothing found. And as part of the workup, she had a mammogram. At 38, mammograms are a disaster because the breast is very thick, the tissue is thick, and it's very hard to pick up tumors. And so the report came back, can't exclude a tumor in the breast, one of the breasts. That led to a needle biopsy, negative. That led to an open biopsy, negative. The end result was a very happy family, no cancer, but a very expensive workup, and a test that should never have been done. Never have been done. Just a further expense to the healthcare system. Anyway, so here we are, here is the dilemma. We have a problem with not enough medical schools, not enough students, a bad mix, and a costly system. So what do? Well, the first thing we need to do is we need to increase the number of medical schools. I know it sounds like 143 sounds like a lot of medical schools, but 18,500 graduates a year does not meet our needs. There are a number of doctors who retire, who die. The increase in our population requires at least 30,000 graduates a year. If we turned out 30,000 graduates, a lot of American medical students, student applicants would get into school here instead of having to go somewhere else. And we wouldn't have to rely on foreign trained and foreign educated, foreign students who are trained in other countries to make up our shortage. It really is a scandal in a way because we're taking the best of the best from India and Pakistan. They come to this country, they train in this country, they fill in empty slots that we don't have enough students for, and they stay here. Why do they stay here? Because they like the lifestyle and the income. Most major medical centers today, if they aren't the famous ones like, again, Hopkins or Harvard or Yale, have primarily foreign medical students, foreign graduates making up their house staff. I would guess, someone nodded, I would guess in Syracuse at the Health Science Center, we probably have about 60 to 70% foreign-born, foreign-trained students. So we need more schools. We probably need to graduate about 30,000 students a year. That means 120,000 medical students. 120,000 versus the current one of about 75. That's a huge increase, but we need to do it if we're going to get enough doctors. And we have to change the mix. The mix is going to be a huge problem. America loves the specialist system. We even have a thing now called the subspecialist. We have the orthopedist, who no longer just treats every bone disease, they just treat problems with the hand, or the hip, or the knee. We have ophthalmologists who only treat retinal disease. They don't treat all eye, they won't do general ophthalmology. They just do retinal disease. So we love the mix, and the medical societies would fight mightily to prevent change. And finally, we have to change the way we fund healthcare. Here's a paradox. You know, I talked earlier about fee-for-service as the way we pay doctors. It turns out that at our major medical centers, the ones I've mentioned previously, the actual cost to the healthcare system, to Medicare, is less than it is in centers where, in places where they're paying individual physicians. Why is that so? Because at Mayo and at Leahy, the physicians are on salary. It doesn't matter how many people they see. It doesn't matter how many tests they order. Their salary is the same. And so, surprisingly or not so, maybe not so surprisingly, there are fewer tests done in those places. And yet the outcome is probably the best in the United States. The best in the United States. So we have to change the way we fund healthcare. We have to do away with fee-for-service. And that will be a huge problem. Doctors love fee-for-service. And the AMA has a huge lobbying group in Washington that would fight mightily to protect what we have in place at this point in time.
It's the capitalist system.
Huh?
It's the capitalist system.
I guess so. Yeah. It's a capitalist system. So these are the things that need to be done to straighten out our current numbers problem and our mix problem. More schools, more students, change the mix, and change the way we're funding healthcare. The chance of doing these things at this point in time is zero. Won't be able to do it. The resistance from the medical profession, and I think from patients, would be enough to prevent some of this. What I do think is going to happen is that over time, the cost of medical care will reach the point where it is no longer affordable in this country. It has been going up a little bit slower in the last 3 or 4 years because of the attention drawn to cost that came about as a result of the Affordable Care Act, but it continues to go up. And there will be a point in time where we cannot afford the luxury of the current system. And when that happens, then I think we will see change. But that's going to be a while in the future for sure. Let me talk in the last 5 or 6 minutes about cost, because cost is a real problem in this country. And I think maybe most of you don't understand why it's so costly here. I have talked about one reason, and that's how we fund the doctors. But actually, all elements of the healthcare system are gaming it. Gaming means taking legal advantage of a system. I talked about the doctors. The more tests we do, the more income the doctor has, but the more cost to the system. And we are trying to get a little bit of a handle on that. But everyone else is gaming the system. The hospitals are gaming the system. And let me tell you how the hospitals game the system legally. When you go in the hospital, let's say you have pneumonia, and you're admitted to the hospital gets paid from the third-party person, whether it's the Medicare, Medicaid, insurance, so on. They get paid by what is called the DRG, the Diagnostic Related Group. And let's say arbitrarily, because I have no idea what the number is, that for pneumonia, they get 5 days of pay. And that price per day is worked out. You see bills when you leave the hospital have everything itemized. That's not the way it's paid for, actually. Not the way it's paid for. Every year, in advance, the cost per day is worked out with the various third-party payers, and that's the price per day. So if you go in the hospital and you have pneumonia and you get treated, and the DRG says 5 days, and they can get you out in 4, they get paid for 5. So there is a huge amount of pressure to get you out of the hospital early. The Medicare people recognized what was going on, and they passed a law which said that if you're readmitted to the hospital within 30 days with the same diagnosis, the hospital is penalized. But that rarely happens. In addition, the hospitals play another game. And again, it's perfectly legal, and everybody does it. It's like when Trump was criticized for the fact that he's gone through a number of bankruptcies. He said, it's legal. I'm merely following the laws. Well, the hospitals are doing it legally. If they can piggyback diagnoses, if, for example, let's say there was a little element of heart failure on top of your pneumonia, they can lengthen the days of the DRG, and they make more money. So they are gaming the system that way. The drug companies are the worst of the worst. I think they're even worse than the doctors. And again, my friend there is nodding his head. I don't know whether you've had to pay for medication. Most of you must have. Most of us are on something. the cost of care of drugs has just gone out of sight. The worst example, of course, is this fellow Shreckley, who bought a drug company that had a product called Daraprim, which is used to treat a rare fungal thing that occurs with AIDS. And he took the price, which was something like 75 cents or $1, and he raised the price to $750. And when he was asked about it, he said, I should have charged more. All of the drug companies are taking advantage of the system. How do they do it? Well, in the negotiations with the federal government for Medicare, and actually, well, no, that's not quite true. I'll come back to that in a moment. For Medicare and all of the insurance companies as well, they negotiate a price. The federal government gives them a free hand. They can charge whatever they damn please. There's no pressure on them to reduce price. You can buy a drug in this country, let's say an antibiotic, let's say a Z-Pak, and you can pay, well, that's not a good one, but you can buy a medication in this country and pay, let's say, $40 for the prescription for 5 days of treatment. And you can go across the border to Canada and get the same drug for half the price, made by the same company. Why? Because they can charge whatever they want in this country, and they can't do, I will get to it, I'm going to be done later in 5 minutes. Because in this country you can charge whatever you want, capitalist system, free enterprise system, but in these other countries the drug companies are controlled. They can't do that. And so they can't game the system except in this country, and they game the system. So we have the drug companies, the hospitals, and the doctors all legally taking advantage of things financially. There was a wonderful study that was done in one of the lay medical journals called the New Yorker magazine by a doctor by the name of Gowanda, who's a surgeon, was in Boston, now in New York City, has written a bestseller recently. He became fascinated a few years ago by a publication from the Medicare people, that they were paying, in terms of what they were paying in various parts of the country for health care. And the thing that fascinated him was that in McAllen, Texas, which is right alongside the Mexican border, about 20 miles, 30 miles from San Antonio, the cost per patient was significantly greater than it was in San Antonio. And Guana went down there because he was interested in it, to see why this was so. And what he found was just what I'm talking about. Everybody was gaming the system in McAllen, Texas. The doctors owned the labs, the doctors owned the MRI machines and the CAT scans, they owned the physical therapy departments, and they were utilizing these things far greater than was happening in San Antonio. And that's why the cost was greater. They were legally gaming the system. And if you add to that, and this is very important, sadly enough, the amount of fraud that goes on in Medicare and the blues. I spent a couple of years after I retired reviewing claims from California, Southern California, for our local Medicare. Why Southern California? They had a factory here in Syracuse that had an outlet down in Southern California. And they were increasingly concerned about their costs out there, which were running so much higher than here. And there was just out and out fraud. And we called the Medicare people in Los Angeles, and they told us that yes, they knew about this guy and that he was indeed cheating all over the place, and they were going to close in on him shortly. But there is fraud all over the place. I've seen estimates of the cost of fraud, which are just outstanding, amazing. I mean, it's frightening almost. But not all doctors are upright. Not all doctors are honorable. Fortunately, most of us are. But there is a lot of fraud. So the cost of the system from fraud is every bit as important as the other three issues that I talked about. And it's going to be very, very difficult in the current political climate to change any of these things. There isn't enough money to run down all the fraud, and I don't think the climate is ready to change the way we're currently funding the healthcare system, the hospitals, and the doctors. And I'm almost certain that the drug company lobby is so powerful that it's going to take time to change that. Okay, I've run 11:40, 10 more minutes. I'm going to stop now and take questions because I'm sure people are going to be angry at some of the things I said.
So what?
You're the one who nodded the most, so you get first.
I take a drug that costs $10,000 for each bottle of pills. On the label, it says the active ingredients are made in China. So I looked up on the internet, and it said that 80% of the active ingredients in our medications are made in China or India.
India.
We have very little control of drugs over there. Would you be concerned?
Most of this, the FDA really checks the quality of products in this country and generally protects us. You know, there are a lot of people that are unhappy about the intervention of government into our lives, but the FDA does a pretty good job. Sometimes they overreact, and there's a lot of criticism about the time it takes before our medication is released in this country, but they do protect us. You're right about the quality issue. And some of these things, when they're actually measured against things made in this country, don't show that they're actually not the same potency as they should be. But I think what we get in this country is probably reasonable, and you're safe. You always ask questions.
Orange paper, and I read it quickly because I didn't want to miss your presentation. There's a lengthy article about a pharmaceutical that makes a drug. I forgot what the med was. And in this country, it costs $2,000 a day for this med. And I think it was either Australia or Europe. The same pill is $22 a day. I couldn't believe my eyes. I couldn't get time to go back and digest that article, but it's amazing.
I think the cost for hepatitis C drugs, a course of treatment for hepatitis C, is something like $70,000 or $80,000 for a course of medication by mouth. It's crazy. It's madness. The amount of money the drug companies spend just on advertising on television would allow them to reduce the price of these drugs, yes.
If we want to increase the number of med students in this country, why don't they forgive the cost of going?
Oh, I love that question.
And not do it in the beginning. In other words, when they graduate from college, don't say, you go to med school and you promise you're going to be a family practitioner.
Primary care provider.
For 10 years, then we'll forgive it. No, do it the reverse. Make them that they are responsible for that until the end of 10 years, and then say, you don't have to pay.
Yeah, and we did have something a little like that with respect to public health service. The question was, why shouldn't the government pay for health care if people are willing to pay back by giving time to primary care? If the public health service, I think if you agree to spend 4 years in an area of the United States that needs health care, we'll pay for your medical school experience. You're touching on a subject that's, I think the cost of medical school is out of sight. I think it's indecent. And I think that we should fund medical schools along the lines that you suggest. I think it makes good sense to do that. But we need more doctors. Yes, in the back.
You spoke at length in regard to medical schools. Increasing the number of medical schools would be one of the solutions. And then you also spoke about the mix. You said 60% or more are foreign students. My question is, why don't the medical schools target more Americans into the medical schools? And why don't
I think it is absolutely indecent that all of those students, the question is, all those students, American students who want to go to medical school, have to go to Europe, or the Caribbean, or God knows where, or India to get medical school training, come back here and they function just as well as our medical students who were trained in this country. It's wrong. We should be training those who want to come here.
Well, why do the medical schools target foreign students instead of American students?
Why? Say that again.
Why do the medical schools target more foreign students than Americans?
Well, I don't think they do that. I will tell you this, with respect to the makeup of medical schools. When I went to medical school in 42. We had a quota system. No one called it a quota system. But we had one woman in every class. We had 4 people of the Jewish faith. We had 4 members of the class were Italian, and the rest were basically white Anglo-Saxon. Today, medical schools make up totally different. They're blind in terms of color, they're blind in terms of gender. We actually have, I had to look this up recently, we have in the United States about 53% of the medical students are women. And there are a great number of people who came from Asia who are now medical students. California has a huge number of people of Asian extraction, from China, Japan, Korea, God knows where, Taiwan, and they make up a goodly portion of medical students. There's a lawsuit in California, actually, complaining that Americans are being discriminated against because they're having trouble getting into colleges in California. There's so many second-generation Asians who are qualified, better qualified, or at least as well qualified, and are getting into the schools in California. So we really need to take a look at, I think the class makeups are now reasonable. We just need more. And it's indecent that anyone has to go out of this country to go to medical school. We're so short of physicians. Yes?
Primary care physicians, aren't they also constrained by the time, the payment is tied
Yes, they are.
to the minutes that they see the
Not, well,
patient?
not quite that way. The way you're paid for is you're paid for an office visit. And if you've got a complex problem that may take 25, 30 minutes to unravel, you get paid the same as if someone comes in with a head cold and it takes you 10 minutes. So the pressure is on physicians to see more patients in less time to keep their income up. Yeah, absolutely true. I might say also that I didn't say what makes up the primary care fields. The primary care fields are family practice, the old GP, general internal medicine, I'll describe the difference between those, and pediatrics. Those are considered the primary care fields. I do think gynecologists perform a fair amount of primary care for their patients, but they're the only ones that do it. The difference between a family practitioner and a general internal medicine doctor. A primary care doctor who's a family practice man has 2 years of additional training, and they treat all comers. They take care of children, they take care of adults, they take care of office gynecology. They have a broad range of things they take care of. The general internist does not take care of children, only adults. They rarely do any office gynecology. So they limit their practice compared to the primary care physician who is trained as a family practitioner. And the pediatrician, of course, takes care of children up to the age of 16 to 18, actually. Yes?
With respect to medical,
You're going to have to speak up. I'm a tad deaf at 94, 93 and a half.
in other disciplines like law, business, and other graduate specialties, the market system has resulted in an increase in the numbers of those schools, and to account for the greater number of students who wanted to go to them. So my question, I guess, is can someone who wants to start a medical school, at least, or some existing university, for example, can they at least break even financially if they do so? Or what explains the failure to develop additional medical schools to accommodate the number of students who would like to go to medical school?
Well, let me play a politician and not answer your question. It's amazing when they get asked questions, they never answer the question. And they get away with it. I just don't understand. First of all, the laws of supply and demand do not apply to medicine. I don't know why, but they don't. The price keeps going up maybe because we don't have enough doctors. Maybe if we had enough doctors, then supply and demand would kick in. But at this point in time, it has nothing to do with it. Medical schools, there was some talk in Syracuse just within the last year about the VA and the university getting together and trying to start another medical school that would be primarily focused towards the needs of the VA, I suspect. And having medical schools with a particular focus is kind of interesting, which is what you're kind of saying. I don't see that happening. I don't see this medical school ever getting off the ground here either. Actually, university used to own upstate. And they were losing so much money when the full-time faculty came in. They could afford it back in the 30s and the 40s, but once the full-time faculty came in, the university couldn't afford it and they sold it to the state. It was just too expensive. But I do think that the concept that you raised about training doctors, that if doctors are willing to give back, they should be freed of the expense of medical school. I think that's a wonderful idea. Yes?
What's your opinion of a single payer insurance?
Of what?
A single payer.
Oh, boy. You're asking the wrong man. I'm a socialist. In fact, we are the only country in the Western world that does not have some type of universal health care. We had 46 million people in this country without health care until the Affordable Care Act came in. It's still in the 20s. I think we already have single payer health insurance. About 60% of all health care is single payer. Medicare, government. Medicaid, government. Combination of local and federal. Veterans Administration, government. The people that work in Washington, our congressmen, our president, our senators, they have health care which is government health care. And yet they seem to be confused by or threatened by single payer coverage. 3/4 of the country really is under single payer, the federal government. So I'm in favor of it. I think this competition thing is a lot of baloney. I think the president gave in to this because he knew he couldn't get it any other way.
One of the questions I always have is with the Medicare D program, you know, where you're supposed to make your choices starting in January. And that you can have one plan that gives you coverage that you need, and then the next year they pull the drug or increase it, and you have to continuously sort through. Why don't they have a single payer?
Well, she's talking about the problems that arise each year when you have the option of changing your coverage. There should be a single, you're absolutely right. These different plans, these Cadillac plans, and then these plans that pay for, with a huge deductible, that are really emergency type coverage sorts of things, they're wrong. You need one kind of coverage which takes care of people. That's it. You don't have to worry about the fact that your insurance only covers whatever. We need universal health care. I really believe that, and I do believe it should be single payer, but that's me. I'm unique in the medical profession. I'm the only one that says that. You say it too. Yes.
When you talked about
Gaming the system.
I thought maybe you discussed the lawsuits that are.
Oh, yeah, the question is lawsuits and the role they play in cost. They play a role. The tort system in this country as it relates to health care is just ridiculous, and it runs up costs. It's not the major player in terms of cost, but it is a player, and we need reform. And, I mean, I don't know if you watched the news the last day or two, but there was a lawsuit settled in favor against Johnson & Johnson. The lawyers claim that their baby talcum powder caused carcinoma, cancer of the ovary. There is absolutely no studies that prove that's so. But unfortunately, a jury decided it was, and there are going to be all kinds of litigation with respect to this over the next decade. We need reform. We have to protect people from the system, but we have to protect the system from the lawyers.
Trying to protect themselves against lawsuits.
How do you protect?
No, do you think unnecessary testing sometimes gets done trying to protect them?
Unnecessary testing is often defended by doctors as saying, well, we're trying to avoid a lawsuit. That really doesn't hold up. It really doesn't. I wish it were true, but that's not why lawsuits happen because of malpractice or perceived malpractice. Sadly, the cost, and I don't even know what it cost. When I was a young doctor as an internist, it cost me, I think, $750. I think today internists are paying over $20,000. And I think neurosurgeons and OBGYN people are paying in the hundreds of thousands for protection. It's really ridiculous. There's someone back, yes.
Would you comment on David Muir's comment saying that the third leading cause of death is physician error?
Would you repeat that for me?
David Muir recently commented that the third leading death behind, I think, cancer and heart disease was like accidental.
Physician error.
Physician error.
Is the third leading cause of death.
Boy, that's a toughie.
And they want to have.
No one's perfect. And mistakes are made. I know when I had patients in the hospital, I would always tell the patient if I ordered a test or changed a medication that I was doing this so that they could protect themselves from errors. It's estimated that at least 1 out of 4 patients in hospitals actually experiences an error. The errors are sizable, sad to say. Most of them don't seriously alter outcome, but some do. And it happens. I just don't know. We're talking about errors, and there's no way around it. They happen. And you have to protect people. On the other hand, people themselves, I mean, I don't know if you saw this figure, but last year there were 47,000 overdose deaths in this country. 47,000. We get unhappy when 10 soldiers were killed in Iraq in one day. 47,000 people. Divided by 365, I can't do it in my head anymore. I used to be able to. It's a sizable number. Between overdose drugs and guns and cars, we kill close to 100,000 people in this country every year.
As you know, one of the candidates running for president is advocating total health care. The other candidates are saying that it would be impossible to pay for total health care. Can you speak to that?
Very, very good question. How do we pay for total health care? Well, you have to pay for it through taxes. I know if you're a Republican, that's a 4-letter word. You can't say that, but in point of fact, you have to pay for what you get. In Scandinavia, as you know, socialist countries, they pay a great deal of taxes, but they have total coverage. They have free colleges, if you qualify. They have free medications. They have free health care, but they pay for it. Nothing is free. You know, people say to me, well, you know, we have 46,000 people without health insurance, but they get care. Sure, they get care. They go to emergency rooms. They're admitted to the hospital, sicker than most. Who do you think pays for that? We do. The hospital doesn't write it off. They raise their fees, their daily per diem fee to the third-party payers. Sooner or later, everybody pays. So why not cover them? It makes no sense not to have universal health care. There's no free ride for health care, even for people who can't afford insurance. We're paying for it.
In this country, though, there are less people working, less taxes coming in, so how is it going to be paid for?
The question is, in this country, there are fewer people working. We have a lot more older people retired. And the Republican
Unemployment is
Party
very
has been
high.
on a campaign to lower taxes. and I respect that. I'd like to pay less. I'd like to pay a lot less. But I think a country's major asset is its people. Not the oil in the ground, not the silver in the mines in the Sierra Nevada, it's its people. And as its major asset, I think that its health, its education, and its protection from harm, whether it be criminals or outside forces, Arab terrorists, they take precedence. And that's my belief. I'm probably alone in this room when I say that. Yeah. Yes.
It's not only one thing. If we looked at all of the things that people have suggested, universal health care, incentive for kids to go to school to become doctors, control the pharmaceutical companies, don't have fee-for-service, salary some doctors. If you did all those things, we could afford to pay for universal health care.
I agree. I agree.
It's not just one thing.
I think we have, I don't want to get into politics. Over.
I think I've heard it once expressed best, is how we view healthcare. Is it a right or a privilege?
Oh,
And it
boy.
depends
I'm
on
so glad
our
you said that.
personal values.
Yeah, the issue is how, and that gets back to my point I just made. Is healthcare a right or a privilege? That's a favorite question I ask young people. Is healthcare a right or a privilege? I believe it's a right. I don't think because you happen to be Donald Trump with billions of dollars that you should get better healthcare than you or I sitting in this room whose income is far less. I think it's an absolute right. Thank you for asking me. Favorite point of mine, yes. But again, I'm probably in the minority. I have a group of friends who are well-to-do, and when I ask them that question, the answer is just the reverse. They think it's a privilege. Yeah, it's a privilege.
They're privileged people.
Yes.
What do you think about, I think they're called concierge doctors, who drop all their patients and now take new
Question is
patients?
concierge medicine.
Right, so now you can get in because you pay $1,500 or $2,000 a year,
Yeah.
and they take, they drop all their old patients.
That's really occurring primarily with primary care providers. You don't see concierge care with specialists. And concierge care means you pay a set fee and you're guaranteed care throughout the year by your doctor. I think it's a cop-out. I think if I had a doctor who did that to me, I would go find another doctor.
It's a way to retire on more money.
I would not sign up. You haven't asked a question. You always do.
Well,
Yeah, he did.
He did
I do have
first.
a statement to make.
Good.
I think we can overcome this whole matter if we get healthy and stay healthy and flip the bird to them all.
Well, there's no question that we play a role in healthcare. When I talked about longevity, I pointed out there are certain things we do that shorten life, and there are certain things we do which prolong life. And in this country, as you know, we have, and I don't see much of it in this room, that's for sure. We have an epidemic of obesity. We have a large number of people using drugs, abusing drugs, and it plays a role, and frankly, in our healthcare costs. Absolutely right. Obesity is associated with hypertension, high blood pressure, and diabetes. Claire, I'm going to ask you, what's your question?
So there was this fascinating book that came out this year by Joe Marchant called The Cure, something about the mind over body. And I know it sounds very fluffy, but she had this very convincing argument that Americans don't properly look through the body of research about non-invasive medical care that has better or equivalent outcomes to all of these testing.
I can tell
And
you
like
my...
fake surgery. They did something where they convinced a woman that she had been through a surgery and overnight she was better, but she never had surgery.
We're talking about a broad subject of alternative health care.
Cure?
We have seen an explosion in alternative health care options in this country in the last 50 years. And the reason they have occurred is because there are a lot of situations where traditional medicine doesn't solve the problem. And I've had patients say to me, you know, I've had this backache and I've gone to the doctor and I've had all this done, nothing helps me, and I go to a chiropractor and he manipulates my back and I'm better. And I say, great, great. If traditional medicine has failed you and you seek alternative medical care and it works, great, do it. Absolutely do it. We do not take care of all things well, that's for sure. So the answer to you is, yeah, we should. Some people will find great relief in that. Someone had a hand raised, yes.
Is it true that in Europe and other places there, people aren't given as many prescription drugs?
I don't know that, but I do know that the cost of medication is covered in many countries, or the cost is far less than it is in this country. And
They say they don't prescribe as many.
well, the question is, do they prescribe less medication in Europe and in Scandinavia than we do? Probably. We're pill happy in this country. We all take pills. I remember as a young man being with a group of people who are much younger than I, and I asked that question, how many of you take a pill a day, and not the pill, but pills? And almost everybody raised their hand. Doctors prescribe lots of medication in this country, unnecessary, but done because of the pressures of time or the demands of the patient. I had a patient once come to me with a litany of complaints, none of them serious, and I said to her finally, after answering all her questions, I'll see you when you need me next. I'll see you next when you need me. And she said to me, aren't you going to give me a prescription? I said, no, you don't need anything. What kind of a doctor are you that you don't give prescriptions? I said, a good one, a good one. I never saw her again. She found another doctor. Yes. Wow, what a spirited group of questions. I love this.
What about kickbacks to doctors on the drugs that they
Kickbacks.
prescribe?
What are the kickbacks from the drug companies to doctors? It is absolutely happening. It is unconscionable.
Is it illegal?
No, no, not at this point in time. In addition, although you don't know this, doctors have regular visits from men and women who work for the drug companies pushing their drugs, their new drugs. And it used to be men, now it's usually a very attractive one, if it's a male doctor. And they give you all kinds of little gifts. And then the drug companies will throw dinners or have followed with tickets to entertainment sorts of things so that you can listen to one of their paid doctors pitch their drugs. I think it's terrible.
Well, there was a short to-do about the doctor who was prescribing cancer drugs to patients who did not have cancer.
Oh, that was
causing us, terrible harm. I just don't understand why the kickbacks are not illegal.
They should be, shouldn't they? Yeah. Kickbacks should be illegal.
Cut back.
Way in the back. But speak loudly.
Okay. You outlined a litany of problems related to the healthcare system.
Not enough doctors, not a bad mix.
But what my question is, and you also said you prefer to steer away from politics, but given the fact that all of these specific interests, such as the pharmaceutical industry, have a very powerful lobby in Washington and elsewhere to basically retain the status quo, is there any hope? I mean, for example, there's a political proposal to terminate Obamacare and replace it with something else, but no alternative has really been proposed. I mean, are there any politically viable possibilities as far as?
I'm sure you could all hear him. I think the answer to that is no at this point in time. I just don't see it happening. The powerful interests in Washington and the Washington system are such that I don't see it happening.
And why is it that when the people in power, government-wise, are voting on healthcare plans for us, they're not voting for what they also get?
That's because they have single pay. Question is why, when they're voting on health care for us, they don't do anything about their own health care? Because they have single payer health care. They're happy with it.
Yeah, but they get the
It's
same
just they don't want it
treatment.
for us.
Right.
How many votes did they take to overturn Obamacare, when they should have been than coming up with a plan that they
It's
think
really
is
the,
better.
I think it's the Affordable Care Act, the ACA.
46 times or something.
It's, I think it, but you know, it's me, I'm,
There was something on RVO just yesterday or the day before, questioning whether hospitals who have $300 million of profit should still maintain their nonprofit tax-free status.
one question is hospitals making lots of money and they're non-taxable. That brings up other issues as well, but you're right, I think.
Churches.
Churches, yeah, churches, I mean, you know, so much stuff is off the tax roll that it really hurts us, but yeah, that's true, yeah.
Do you think a lot of the overuse of prescription medicine is due to the fact that it's legal now to advertise it on TV
I
and
do.
newspapers?
Do I think that the advertising plays a role in prescription stuff by doctors? Yes, I do. People come in and say, oh, I just saw this ad on television, and so why aren't I on that medicine? Sometimes the doctor will prescribe it, sure.